Hello, and welcome to episode number 429 of the Armen Show podcast. Science, people, creativity, learning more, always expanding our framework. Sometimes we have new guests. Sometimes we have returning guests. Today we have a new guest, Professor Camilla Nord, who leads the Mental Health Neuroscience Lab at the University of Cambridge. She has a book, The Balanced Brain, joining us from the UK. Welcome, Camilla.
Thank you so much, Armen. It is wonderful to be here.
I'm happy to have you on. You have written a book in the neuroscience category, which is what you cover. I'm very interested in that category and cover it fairly regularly. And earlier this year, you gave a talk at the Royal Institution in front of many people about mental health, exercise as it relates to well-being, various topics related to the brain. How was that talk? And how are talks in general? Do you enjoy them?
More than I used to. So the talk that you are referring to was quite a kind of public talk. So speaking to kind of a big variety of people, which as a scientist, there's an element of discomfort. Okay. So as soon as you have become a specialist on any topic, it doesn't even have to be science. The second you go outside of an audience of specialists, you panic because you are like, oh my goodness, if I say anything even a little bit too far, people will take it the wrong way, maybe think it's more exciting than it is, think it has more implications. So anyway, scientists are really bad at this, and I'm absolutely in that category. But over the years, unfortunately, I kind of love the discomfort of it. It starts to challenge the assumptions that we use on a day-to-day basis when we speak with other people in our kind of sub-disciplines. There are things that never get questioned. And the second you get some so-called non-experts in the room, all of a sudden they can shake your very foundations and make you really think about, why are you researching this? Why is it important? And all of the big questions I think we should be asking ourselves more frequently.
This is great. Quality discomfort is very healthy. Is it positive? Do you seek discomfort? Has that always been part of your nature? Is it good for us as people?
I think it has been part of my nature, or at least I think I am probably a little bit of a weirdo when it comes to a phenomenon that psychologists call delay discounting. So everybody values faraway rewards less than proximal rewards. This is quite adaptive because the future is uncertain. So the most famous example is kind of children and the marshmallow test, preferring to eat one marshmallow now versus two marshmallows in a while. And that sounds like, oh, silly children, they should wait to have the two marshmallows. But actually, there are very good reasons why you might want to eat one marshmallow now. Do you believe the person telling you that you're going to have two? What if there's, some kind of crisis in marshmallow production in the near future and you're never going to get your second marshmallow? There are lots of reasons why you should delay discount. But I think, you asked a personal question, and I think I'm actually quite bad at this phenomenon. I can delay rewards, sometimes to the point where euphemistically, there's a marshmallow deficit. By the time I get there, there's a kind of, and I think you have to have a bit of this trait to do a PhD, and you have to have a bit of this trait to like discomfort in the sense that you kind of see the long-term rewards. But I also think there are cons with having this trait.
I think about that category quite a bit, whereas the amount that you are able to put an idea out further into the future is as far as you will get. I see that as like the limitation. The as far as you will get is as far as you can map it out and keep yourself to that. That's my thought on the matter. That's a cool quality that you have. So right, it sets us apart. That marshmallow experiment always talked about in so many books on instant versus delayed gratification, very important category of interest. Before we get into some of the material from the book, how would you describe what specific categories you tend to focus on in the neuroscience world?
So my lab is called the Mental Health Neuroscience Lab, and my expertise has always been, so for more than a decade now, studying the brain basis of psychiatric and neuropsychiatric conditions. And the way that I do that, there are sort of different ways one can do that, but I'm a cognitive neuroscientist, so my training is all in human neuroscience, neuroimaging, brain stimulation, computational modeling of human behavior. So I have some kind of loose animal collaborations, one more recent than the others, but mostly it's work in human neuroscience, but always with this kind of clinical application. I began my interest really in depression, and I talk probably more about depression than other mental health conditions in my book, but as it's sort of revealed in the book and has been revealed to me in my research, I've moved away really from the idea that there's a kind of unitary condition called depression that we can understand the brain basis of. And much of my research now is really looking at the kind of dimensional phenomena that can lead someone to experience a condition like depression, but probably also other mental health, and more recently in my work, physical health conditions.
What are pieces that can put a person into a state of depression? Is it behaviors? Is it actions over time? Is it the people around them? What stands out?
It's a really hard question, and I think the only way to truly answer it is clinically. Back in the day, we used to think maybe we would be able to diagnose depression with a brain scan. Well, maybe there are still people who are sort of endeavoring to do that, but I actually no longer think that is a useful pursuit. What would it mean if you had a brain signature of depression, but you didn't have a clinical experience of depression? So the clinical experience of depression is feeling sad, low mood, etc., almost all day, almost every day for at least 2 weeks, and or a lack of pleasure or interest in normal activities, again, almost every day, almost all day for 2 weeks. This is an unusual phenomenon. Sometimes people experience facets of depression, but they are not experiencing a major depressive episode. And I do like to make that distinction because actually, whilst I believe some of these things are, on a spectrum, there is an aspect that isn't on a spectrum. You either are really disabled by your mental health or you're not. And that's a binary thing.
I like that you brought that up. That's so key, that there's the binary versus the everything flows methodology of thinking about aspects. And if you never get into placing delineations on what you're looking at, you can't identify solutions or items of recourse or a way to alter that. It takes away from ambiguity, takes away from a potential diagnosis. Is that fair to say?
Yeah, more and more, I've come to believe that there are some processes that we understand. So in my world, it might be neural phenomena, it might be hormonal phenomena, etc., that influence things, on a quantitative scale. The more extreme you are on this, the more likely you might be to develop a mental health condition or conditions. But I also think there are some phenomena that are more qualitative. A qualitative distinction between having functional impairment and not. And sometimes these are the things that are most common across disorders. So for example, if you experience, really extreme challenges in childhood abuse, for example, that's not to say you'll necessarily develop a mental health condition, and it certainly doesn't predict which one you'll develop, but it is a common risk factor for developing any mental health diagnosis. So that probably does move you along that kind of functioning spectrum. Are you going to be affected by your mental health symptoms such that it will affect your functioning? That's just one example. There are probably others, genetic and environmental.
Is it kind of reasonable to think about it like comorbidities for health that cause a person to end up very unhealthy? Same thing with the mind state of depression, that multiple factors, you could call them comorbidities in that category, can put someone in that zone that they are now stuck there.
Yeah, exactly. Many, though probably not all, of these risk factors kind of can predate multiple different conditions, and that's true with physical health as well. And we are starting to think, so in my field and in my lab in particular, we've become interested in factors that might precipitate poor physical and poor mental health. So one of the ideas that I sort of try to overturn in my book is this artificial separation between physical and mental health. And in The Balanced Brain, I really argue that we need to look at that in a much more nuanced way, both one, because physical health affects mental health and vice versa, but two, because actually the lines that we've drawn are pretty artificial and often end up putting patients in kind of weird categories the second we find, you know, a reason for your mental health problems. Like, say you have some kind of autoantibody encephalitis, which is what happened with a group of patients now about a decade ago. You get reclassified. All of a sudden, you're not a psychiatric disorder. So I don't think that's how it should work. I think we should think of kind of all of these conditions as disorders of the nervous system and do our best to understand them in that full picture.
I once asked, it was a doctor in Northern California about this, wondering your thoughts on this. If you were to give a grade on how descriptions of people are made when they come in to get a diagnosis and their treatment is fitting to that versus they're not in the right place or they don't get sent to the right doctor, like the accuracy of the treatment to the person, what would you give that grade, let's say in the UK?
It's hard because it massively depends on the service and the problem that someone is dealing with. I think there are, you know, really positive psychological treatment services in the UK, for example. So we have free psychological treatment here. You have to be on a very long waiting list for it, or sometimes 4 months, 6 months. But then at the point of access, I think often clinicians are quite good at matching psychological therapies, at least within that category, with the problems that you're presenting with. I think what they're less good at, so, you know, maybe that's like a B plus given the wait list, but I think the problem to me is that what we are bad at, what we don't even try, what we completely fail at or get an incomplete on, is in differentiating, you know, considering all treatments together, psychological and sort of what we might think of as biological drug treatments, non-drug treatments like brain stimulation, which I talk about. Nobody thinks, will this patient be better off responding to this group of drugs or this group of drugs or this psychological therapy? It's just kind of like, what do you want, which is one factor, and what is available right now. And that, I think, in the end, that we end up having patients take longer to find successful treatments. In the end, that's a more expensive approach. And so what we need is a kind of better fingerprinting of who should get which treatment. And we don't do that at all.
Okay. Now, switching categories here, you have a chapter in your book, Motivation, Drive, and Wanting. I've always been focused on motivation, rewards, those pathways. How much should the average person protect their reward pathways from cheap dopamine or items that usurp their pathway and now they're on a different path? How important is it to protect it, or is that something that someone can do?
I was really compelled to include this chapter in my book. It was actually the first chapter I wrote because I think it is a neglected area, specifically motivation or drive, a neglected area of mental health. People think about some of my other chapters, pleasure, the relationship of the body. They don't think about motivation, and boy, should they. I think motivation and the kind of neural pathways that underpin it is probably the most important precursor to mental health. Everything else depends on it, because you're never going to experience positive things if you don't have the drive to experience things in the first place. Disruptions in these pathways can have profound impacts on someone's mental health, even in the context of neurological conditions like Parkinson's disease, which often comes with apathy or lack of motivation. So I personally think these pathways are central. The degree to which we should preserve them, so I would say yes, but then I would also query exactly how. I think it's very messy whether you want to avoid things that stimulate these pathways. I don't think there's really solid evidence for that. Whether you want to use all the time things that artificially stimulate these pathways, like drugs, I think probably that's an unhelpful outcome as well. But I don't necessarily think there's evidence for abstinence in the way that I think there might be evidence against, like, dependence on a dopaminergic drug.
It's true. it's harder to get into the what to do versus the this is definitely not the category of
Exactly.
things.
Yeah.
Those will take you down the wrong path.
And
It's
on
almost
that, I
like
mean, I'm curious what you think about the idea that non-drug rewards are bad for these pathways. I'm actually a real skeptic about it. There isn't solid evidence that things like screen time are somehow unhelpful for the dopamine system. And yet I feel that in popular media we're being told that all the time. But there is no really like I have not yet found any strong evidence to that effect. What do you think about sort of behavioral sources of these pathways?
I've thought about this quite a bit. Glad for the question. In response, I think that I look at myself, sometimes me specifically, I'm very able to, I feel like I'm a walking prefrontal cortex, so I'm able to executive decision make beyond what is in front of me. But I don't think that's very common for the public. But I would say, if I speak from my end and what's possible, I agree with what you were saying, that it doesn't really throw me off to that capacity unless it was something that I was fully engrossed in, which I've never really been. So I agree with that, which counters what is mentioned a lot. Jonathan Haidt wants to, or doesn't want to, but he's talking about how in like New York they will reduce the screen time by having schools where you cannot have your phone in the school. That might be a thing. He has his book, The Anxious Generation. So there's a few of those individuals that screen time is like the issue, or attention span also talks about that by Gloria. I forgot her last name, Gloria. And so that category is mentioned a lot, but yeah, this counterpoint is very important. It's not necessarily as strong unless it's one of the items that completely derails you, such as maybe hard drugs, which maybe those individuals would not partake in the first place. Do you see a lot of, would you say this is a common thought pattern among colleagues that you have, or not so much?
Yeah, I think, I think one of the challenges of this space is that everybody has an opinion on it, and those opinions are, even among scientists, difficult to separate from kind of cultural mores. And in my book, I talk a little bit about the reactions of the popular press to the waltz a very long time ago. And you wouldn't be shocked that actually the phrasing is much like the way that some of our newspapers write about, TikTok obsessions. And so I think with the arrival of new cultural phenomena comes concerns and pushback and anxieties, especially about older generations, especially coming from older generations about younger generations, I should say. So I think that's an undercurrent no matter what. I'm not saying that explains the entire phenomena, but I think that is one important part of it. And then, I suppose the other problem is that in addition to everyone being interested in it and having an opinion on it, popularly within science, there are a number of studies, and they are often too small. They are often confounded by other factors. They are almost always unable to disentangle causality. What is the source of any purported association between screen time and mental health? And so to my eye, this means that there is very much an open question. Sometimes the causal studies go in the opposite direction. There was a school intervention recently where people's mental health seemed to worsen when teachers took away their mobile phones. Having said that, I actually have no problem with schools without mobile phones. I don't see a real downside to that, except if there was some interesting thing coming out of this study that I mentioned. But there could have been, I think everyone would see that study and go, oh, but maybe there was a confound, maybe there was something that caused this. But then the studies that kind of agree with their assumption that it's bad for their mental health, they don't critique in the same way with the same rigor.
You bring up multiple good points here. It's very difficult to, well, unless when you're seeing it with the clarity to see potential biases or what is being presented, papers can be of a small piece of a larger thing, and okay, this thing, and so this is the whole thing. And there's a lot of that in today as opposed to, I think, 30 years ago. I get this feeling that some of the larger things have been covered before, so now it's more minute. And then it gets, oh, well, we have the answer here. This one pixel on a whole screen is the answer. And it doesn't also feel as tangible. And they're not, I don't know if they are pulled from as much, some of the more recent articles. But also,
Yeah, I'm happy with people running smaller and preliminary studies. I think the idea, though, is that you consider them kind of as a body. And there are, of
right.
course, researchers who do that, who kind of analyze them as a body. And in contrast, and, just moving away from this topic in particular, but this is a phenomenon across all topics. You look at COVID studies, vaccine studies, what people do is they kind of cherry pick one study that they think supports their particular kind of gut feeling about the way research should be going, and then they use it, and it's sort of like, well, everyone wins because you can always find a study to support your point of view, and everyone loses, really.
100%. There's quite a bit of that. I noticed that. I think this is a portion of why there's a pullback from the social space more recently, because how would I describe it? Like an overabundance of not the actual thing these last few years, and so no one can really attach to it palpably. That's how I feel. That's how I feel that things have been happening recently. One other point you bring up is, this is very entertaining. So yeah, there's like the waltz, things repeat over time. We have cycles that repeat for us over time, and I always think about it like our neurotransmitters and the way we function haven't altered for hundreds and hundreds and hundreds of years. So even though things have been altering outside and we have interesting technologies and whatnot, the way we go through our general day-to-day is still the same reward pathway and cortisol and lighting and the path. Do you think about that as a neuroscientist, that all humans have this shared experience over time and it wasn't so varied?
I do. I think about this in particular with one of the conundrums of my book, of my research topic, really, which is that in my view, in my strong view, mental health conditions are biological phenomena, biologically instantiated, I should say. They are neural phenomena in the broader body, but eventually, no matter where they come from, including social causes, the way they affect you is via your biology. And I've encountered before some real resistance to this idea, some discomfort with it, because of the cultural sort of waxing and waning and inconsistencies of mental health disorders as we call them today. And this is so true. You can find culturally specific disorders that exist in some countries but not ours, heavy leg syndrome, for example. You can also find disorders that have sort of apparently died out in our culture's history, disorders that are currently being found, which is something I talk about a little bit. And how can these ideas be consistent? And I suppose the way I see it is exactly what you've described, that we have this kind of constancy of a neural and biological framework in processing the world, and disruptions that can occur to this from all kinds of different challenges, not in any way specific to the challenges of modern society, but very, very different sorts of issues can affect our own mental health. And I feel that even if we've drawn the boundaries slightly differently over time, that doesn't actually mean that disruptions in this processing kind of come and go in the same way.
True on that. I very much agree with the idea of, I look at consistency as something that speaks truth. So if something has applied for 5 years, 10 years, 100 years, 500 years, the consistency of it says something more loudly than a bolded quote of today or a very pronounced message from 1,000 people today, because the things, it's like a quick impulse on a sine graph or something. If it was high amplitude, the likelihood of it continuing is very low, and earthquakes don't last very long too. Like punctuated equilibrium is very brief, but the thing, most of the time of reality is the general calm equilibrium or low peaks. So I think about that as far as people and consistency. Is consistency related to a person's well-being, or does it represent that they have a balanced brain?
My book is called The Balanced Brain because of the type of equilibrium that you're referring to, except in the context of the brain. So in the way that our body seeks homeostasis to deal with challenges like dehydration, lack of nutrition, etc. So it kind of helps us remedy those deviations from homeostasis. So too, our brain needs to respond to challenges all the time. And I don't think these challenges or our need to respond to them are necessarily pathological. We survive by dealing with mental as well as physical challenges. However, the way in which our brain responds to these challenges, predicts the next challenge, and sort of most importantly of all, develops a kind of overarching belief system about its own abilities to deal with these challenges, that ends up constructing our mental health. So it's through these balanced processes, through the balanced brain, that our mental health is constructed. It is disruptions in these balances, disruptions to this very balancing process that can help, that can, precipitate a period of mental ill health, but that the same processes can help someone be resilient to even quite enormous challenges to their mental health.
The resilience, I always think about that early in life. I've seen many papers on this where a certain amount of challenges, great. No challenges, not great. Too much, like over beyond trauma, also not great. So there's a sweet spot of you're challenged, but you're not broken into pieces of sorts, if you will. I've seen papers on that. Now, one thing that comes to mind is our brain as a predictive machine. Do we benefit from, how important is it for us to have our predictions of the world match what happens? If that does not happen enough, do we start to have dis-ease within ourselves?
My book is very much an undercurrent throughout. It's a predictive brain book. So I agree with you, of course, that these predictive models are essential to our mental well-being. I suppose the way I see it is that they're essential to everything from extremely low-level perception to these very high-level beliefs about the world. And the ways in which information can support or contradict our beliefs, varies in complexity. And as you sort of move up this hierarchy of abstractness, so does the information move away from a kind of concrete observable phenomenon and become more and more dependent on your priors themselves. So even the contents are so filtered through your expectations that it can become, perhaps even more difficult to move away from entrenched biases, maladaptive beliefs in kind of clinical psychological terms, but because the information itself is ambiguous, complex, and subject to interpretation. So it can look confirmatory even when it is not. An interesting example of this is in the context of phobias. So a conundrum for clinicians is that a good therapy for phobias is exposure therapy. Is something I'm very interested in. It's very effective. If you have, say, a phobia of crowds, and then your therapist sort of works with you, you do these sort of experiments where you expose yourself to crowds a little bit more, and then, the idea is eventually you can be in a crowd without having a panic attack. And that does happen to many people. But for some people, you get in a little bit of a predictive coding paradox, which is when you're in a crowd, what you're supposed to be learning from a classic clinical psychology framework is that nothing bad is happening. But unfortunately, it feels terrible. It feels like your heart is beating, you can't breathe, you might pass out. So nothing bad is happening from some sort of objective observer point of view, but from your point of view, which is the only point of view that matters, something bad is happening. And so that can mean that exposure therapy can fail if you are still experiencing, in these kind of safe experiments, if you're still experiencing negative physiological, psychological phenomena, then unfortunately it becomes much more difficult to shake your beliefs about those situations.
Very important point here that the person can come out from the experience and they did not see it as it was, and so they might come back such that, let's say it was a socializing experiment. I've had a couple of individuals on. Ruben, he has a channel where he takes out the people to socialize in public and express themselves more openly, and some of them, it matches closer to what actually is occurring, the feelings that they have, and they do feel like I've grown a little bit. But some of them, you would think they had reached out a little bit beyond their skill level and understanding, but afterwards they're like, that didn't go well. Shoot, I can't believe how that occurred. And you're like, did we see the same movie? So in that case, what you're describing is very important, because they would maybe go back home and think, that didn't go too well, I was right, that kind of thing is out of my range. Even if to the outside world nothing occurred, there was no damaging situation of sorts. There's a separation between those two.
Yeah.
Mm-hmm. It's cool to do those kinds of experiments. Social experiments are very popular on the internet. The same thing that would be done and it would be looked at as odd if it's described as a social experiment, people are like, I get it, I understand what you're doing. This person is growing, which is good. I like to see growth. How do you look at growth as a neuroscientist how much growth is tangibly possible, let's say beyond age 30? What can be done? Is a person still malleable? How fixed are they in place?
I think neuroscientists used to consider people much more fixed than they are. I have sort of grown up post, the various adult neuroplasticity studies suggesting that there is still, neurogenesis, neural shaping, even anatomical changes that occur as a result of experiences in adulthood. So I probably find myself in the perspective that there is still kind of biological reshaping that happens in adulthood. Maybe one of the most obvious ways this is possible, although it's unfortunately really sad, is that if you experience a horrible trauma, it can happen when you're 40, it can happen when you're 60, and you might develop PTSD. Unfortunately, you might develop really profoundly disabling symptoms that will affect the rest of your life if you don't have good treatment. And so I think that's just a very obvious example of how something happening later in life can have a profound effect on you. But if you look at the implication of that is that not just bad things can happen to you. Very many very positive things can happen to you throughout your life and change you.
Forks in the road, as I call them. I always whenever I talk to people about their lifetime, there's moments that are a fork in the road. It could be like a traumatic event like that, or meeting a certain person can be. I usually ask that later, but actually, is there a person in your existence that has provided a fork in the road that led you to where you are today?
Well, I mostly wrote a nonfiction book about science, but it does incorporate some threads from the rest of my life, partly because the rest of my life is very intertwined with neuroscience, and some of the people who have been most important to me and in the forks in my life have been scientists themselves. So one of them, I talk about my PhD supervisor, John Reuser, who really changed the way I think about the world and the brain, and really is the reason I became a scientist. I also talk about my wife, who's a neuroscientist. So my wife runs a lab in Cambridge called the Prediction Learning Lab. So she's very interested in the predictive brain too. She's done sort of work on autism that is incredibly important in the field, really like fascinating exploration. And I feel that knowing her in like a personal capacity as well as in a work capacity has of course changed my life, and I feel incredibly grateful both personally and also scientifically to know her.
Very important to have such in one's life. When it speaks to you like that, it can alter your whole years and decades and decades. Also, you brought up autism right there. I once had Dr. Temple Grandin, who speaks about autism, her whole existence on the program, and we got along super duper, which was very nice. But what are your thoughts to there's a variety of people on Earth that have some amount of autism or other descriptors. Is it better for those individuals to showcase it publicly, not much to the public? Is there any good habits or qualities for those who have qualities like that will make their existence smoother or easier with the rest of the people?
I think there is evidence that for autistic people who have autistic traits as well, I think the evidence suggests you shouldn't hide it, in as much as that can, in and of itself, cause stress and anxiety, and it's also just kind of a cognitive burden. And I suppose that's maybe the strongest thing I would suggest. Whether or not there's some kind of advantage to having autism, I think there are advantages to all kinds of cognitive differences. So I would say yes, but not uniquely so. Sometimes I'm a little bit cautious about the term neurodiversity. It sort of originated from a really positive place, but I think has come to mean that what I reject is that there's a concept such as neurotypical, really. I think there are, important differences that should be studied, differences that are valuable in the population. But I'm hesitant that there's some kind of neurotypicality that we should be comparing everyone to.
I am fully with that point there. There's something to it that has always bugged me, such that if you're making a descriptor like that, then you're turning it around and saying the other side is a thing that's the default, and such that it's almost like expiring to the default. It sounds nice. It's one of this past decade, this is the way I describe it, there's a lot of things that sound nice, but if you look at it one layer further, you're like, wait a minute, that's not, that wouldn't come from, nice would just be working with that thing. This is like a layer beyond it that sounds, it's almost like a PR team saying things to cover up the thing underneath. I've noticed way too much of that. So I'm in agreement with your point on that one. That's funny. We have a mesh of views here. Now, you talk about antidepressants. I have a friend, I know multiple people who are on various antidepressants, and at first it looked like it might be a temporary thing, but now it's multiple years for some, and it may be forever for some. Is the general usage of antidepressants meant to be for a period of time, or is this a lifetime item? And also, let's say in upcoming years, will we have technology that will turn it into, it would have been a lifetime item, but now there will actually be some sort of a more clear solution?
Ultimately, I think the class of drugs that we call antidepressants really have both utilities. For some people, the kind of best treatment approach would be a temporary use of antidepressants in a period of time. And then I think there are other people for whom some kind of more long-term treatment is the right option. They're not unique in that respect. There are other drugs that we use medically, sometimes short-term, sometimes long-term, both psychiatric and non-psychiatric drugs. It's maybe the third bit of your question that is the most important. What innovations can we come up with to move more people into the temporary group, or maybe in a kind of temporary but recurrent? Depression is a relapsing remitting disorder, for example, so it might be that the best case scenario is for you to be sometimes medicated. That may be a kind of optimal scenario, but how do we exploit this intervention, which can work so well for some people, not so well for others, to kind of maximize their efficacy when you are taking them, whether that's short-term or longer term? One thing my lab's really interested in is combining biological and psychological treatments in some kind of evidence-based way. So using drugs where we understand the neurotransmitters and other systems that they affect when they are acutely directly used in combination with a psychological therapy, be that exposure therapy or cognitive therapy, sort of pairing the right drug with the right therapy. At the moment, people are often just on a course of SSRIs, and then they at some point might have a course of CBT. Nobody ever really thinks, should they be on SSRIs when they're having CBT? I know kind of CBT experts who've speculated to me that maybe you shouldn't be on SSRIs when you're having CBT. And I would suggest maybe we should think quite carefully about, if you're on a drug, what drug you're on, and is it a drug that could actually enhance the ability of psychological therapy? Is it a drug that could actually weaken the abilities of psychological therapy? And then we should avoid that drug.
This is another layer that would help out in that category. It seems sometimes such that, oh, okay, the medication amount is reduced, then it's increased, then it's reduced, and then 8 years passes, and there's a bit of a just keep things going in some way. Related to this, in the United States, I'm in the United States, and I think it was last year I looked up 8 of the top 25 booming industries or fields to work in or related to some sort of mental health that I noticed when I looked at this list. And would you say it is more that people are, let's say, not well, or more that because the baseline things in society have been taken care of, this is now an advanced layer we have reached for, if you had to describe?
Well, first of all, I didn't know that statistic that sort of ate at the top things. So
from one list that I saw. Yeah.
What, like healthcare or other sorts of?
I looked at, it was like top 25 careers for this year that are upcoming, and like one was actually, once I started to notice the trend, I started to count from the list, because some were engineer, but there was like a mental health clinician or a psychotherapist, or I counted 8 of them that related to our mental well-being in some way.
Really?
I thought that was substantial. That was like 1/3 of booming careers.
Wow. So I've actually I didn't know about that trend. So I'm going to have to think about this.
It was just one list. I'm not saying it's going to continue forever, but
it reminds me of the oft cited trend of increasing mental health problems or mental health diagnoses. And as I understand that trend, there are probably several contributors. One, which could also be contributing to kind of increased careers in that area. One is a positive thing, which is people who in the past should have had help, should have been able to seek diagnosis, treatment, etc., are finally able to. Stigma is reducing, access is increasing. So that's a kind of really glass half full perspective. But I do think it's a true one for some. That accounts for some of it. Then I think there is some of it that may be associated with increased access to services from diagnosis, increased utility of having a diagnosis. So people who might be experiencing levels of clinical symptoms, not necessarily worse than previously, not necessarily kind of like undiagnosed previously, but some kind of like, oh, okay, you know, I'm experiencing these particular symptoms. I could benefit in life by reducing these symptoms. So it's not necessarily like a clinical threshold problem, but it's something where people perceive that could improve their functioning, improve their well-being. Maybe it's a problem you can deal with if you don't have as many other problems, but maybe it's also more recently recognized as the kind of source of other problems. If you have sort of career things, career challenges you want to solve, if you have family relational problems you want to solve, maybe this is a kind of a way to get at those. And people have sort of been reflecting on that recently. Another sort of slightly optimistic interpretation. Then for the negative ones. So lots and lots of suggestion that mental health is somehow worsening at the moment. And there is some evidence for this. So you always have to be careful because it could be the other things. But even if you use like exactly the same questionnaire, there are big cohort studies in the UK that do this in teenagers across time, it does seem like mental health is getting a bit worse in some domains. So there does seem to be some kind of like there. But the cause of this is very open. One suggestion that I sometimes talk about, which is a hypothesis put forward by my friend Lucy Folks, who's written a fascinating book on the topic, is that there is an element of social learning happening amongst peer groups when someone has a diagnosis, and perhaps even an element of, once you label your symptoms as a disorder, that can consolidate and sometimes worsen the symptoms themselves. So it all sounds a little abstract, but actually I'm quite interested in that phenomenon in the context of physical symptoms, and that can be a little more tangible. So if you think about something like TikTok tics, which is a phenomenon that many people heard about, it looked like Tourette's syndrome was contagious via TikTok. I think this is not a nuanced way of looking at it, but I do think there were examples of people developing tics from exposure to other people's tics. They weren't faking them, or necessarily, and some of them might have been, but I think many people were not faking them, in my view. But the tics were being generated by a different phenomena, a sort of predictive brain phenomena, and not Tourette's syndrome, which is caused by other phenomena. So I think when you look at something as kind of visible and tangible as a tic, it becomes maybe more obvious and measurable how sometimes within peer groups, even very broad across the world peer groups, there can be a consolidation, even augmentation of symptoms by exposure to other people's symptoms.
I've talked about something related to this many times. It's a wonderful point you're bringing up. I've described it as the I like to say multiplicative factor, where the way the internet functions and the algorithms, or us as people, and we're connected to the internet more than we were before. If I search for something a few times, now I'm seeing more of it, then I'm seeing more of it, now I'm thinking about it, now it's in my space. If I avoided it in the first place, I avoided the whole exponential connected with that early process. So once you get into it's like falling into a funnel of sorts. So this funnelization expands anything where you put yourself toward that or see that as a thing. And then you'll start looking for reasons where, I guess that was that the whole time.
That's right. And it's not in any way exclusive to online environments. You see this phenomena all the time in person. It's very, you can see why humans would have it. It's a way of helping us understand ourselves. It's a way of figuring out which health things we should pay attention to and which things we should disregard. Signals from our body are so noisy. Our brain has to have sort of some way of telling if something is dangerous or important. But naturally, that means that sometimes it gets it wrong.
Broad-natured question here that is slightly mentioned towards the book. In 2024, what is a mentally healthy lifestyle someone can lead? What are elements of that for the average person? Is there anything that the average person can think, okay, these things that I'm doing, these are connecting me more with the person who has a mentally healthy lifestyle?
In The Balanced Brain, I outline various versions of that, various aspects of a mentally healthy lifestyle, and kind of, I suppose, get really at the evidence for where it is and where it isn't necessarily mentally healthy. A good example of where it mostly is exercise. Huge volume of evidence supporting exercise, particularly for depression. And the evidence is both associative, large studies showing that the more you exercise, the better you feel, the less depressed you feel, and so on. But also causal, randomized control trials that are well controlled, putting someone in an exercise group versus not for depression, and it having a robust effect size on depression. Having said that, a point I make in my book that I sort of stand by, I suppose, is that just because something is mostly true does not mean it is always true. So that is the case with the evidence. But if you look at subsamples within the evidence, so say people who exercise really quite a lot, like essentially every day for many hours, they don't seem to have this association. They have it the other way. So they actually have slightly worse mental health than people who exercise less. This is an association. So we don't know the origins of that, but it does suggest that it's not a kind of simple linear phenomena, more is always better, and that it may be sensible to have kind of blanket, it's generally good opinions, but not to beat yourself up if you are in a group where it is not good for you. I think of a counterexample, something where lots of people do it, but there isn't as obvious a causal link, is for microbiome health and mental health. I think the microbiome is so interesting, and it's a field I follow. I actually do think gut-brain health is very important. Gut health is very important. But I think the causal evidence for specifically improving your microbiome and that having some kind of direct effect on your mental health is less clear. So there are lots of associations. There are many reasons for why those might occur. People in environments that might worsen their mental health as well as their microbiome diversity. There are a smaller number of causal studies, great ones in animals, but animals living in germ-free environments is very, very different than humans living in ultra-germy environments. And so the jury is still out. It's not to say I don't think there's evidence, really strong null evidence either. I just would say if you are not making kind of some big microbiome effort at the moment, that's not a general lifestyle advice, at least when it comes to mental health. There may be, I think there are gut benefits anyway, but.
This is an important. I once spoke with Professor Bill Sullivan. He wrote the Pleased to Meet Me about gut bacteria, and he was on the show a couple times about gut bacteria and how the vagus nerve connects to the brain, and you spoke about that in your talk at the Royal Institution as well. And the link is strong. The food that we eat has such an impact. I've been seeing many articles lately about how the United States has food that leads people to 1 in 2 people will be obese by 2030. And if they go to another country and eat basically the same foods, it does not lead to the same results. And then that obviously affects the mood after the fact. So it's such a strong component, but getting out of the cycle one is in, if they're already eating certain foods, is a tough one. Altering someone's existence is a tough one, I would say.
Yeah, I agree. And I also think that there are many other mechanisms that could, one, explain the link between diet and mental health, and 2, sort of explain what the noisiness of the vagal nerve information is. So the microbiome, some aspects of it do communicate with the vagus nerve. There are also kind of inflammatory aspects that can work via other means with the brain. But the vagus nerve receives so much information. It kind of converges on the vagus nerve. And so it does mean that sometimes one source of information, albeit very interesting neuroscientifically, might not be enough to change that balance of information about bodily health or bodily state. If there are, if there are other systems that are disrupted and communicating with the vagus nerve to say that.
What are the most, this is once again broad, I always go broad because that's how I think about things. What are the most common disorders that come through the neuroscience landscape in 2024?
Within the space of mental health, or even more broadly?
Mental health, I would say.
So I think, one aspect of mental health, which is not my expertise, but incredibly important at the moment, is mental health in the context of neurodegeneration. So we have, vastly increasing numbers of people with different kinds of neurodegenerative disorders. And actually, mental health seems to play quite a big role, even in non-mental health symptoms. So someone's cognitive impairment, for example, is, I think, at least partially mediated by symptoms like depression and anxiety. So it does seem quite important to understand mental health in those patient contexts as well. And I think that is something we will see grow going into the next decade in particular. I think otherwise, the large focuses in mental health neuroscience at the moment have been particularly on treatments for depression, so better understanding of the neural basis of different treatments, but also treatments that directly target neural architecture in the context of depression. So one of my favorite advances probably in the last few years has been the use of accelerated neuromodulation therapy in depression, a really cool application of neuroscientific knowledge, neuroscientific techniques like functional imaging to develop a treatment that, at least in early work, looks really effective for depression. So that's been quite exciting. And then likewise, there's been some really interesting work on deep brain stimulation for depression. These are all stuff I haven't done. That stuff is always elsewhere. But a really cool work on deep brain stimulation for depression. Again, in this case, very early stage, but looking at simultaneous monitoring and stimulation of a region in a patient with depression of the amygdala, I believe. So just really beautiful kind of closed loop, it's called, work, where you can simultaneously look at neural signatures of depression and then try to modify those. That is such an important advance, I think.
Very interesting. If you had one takeaway message you would want people to absorb or understand from the balanced brain, what might that be?
My hope, my biggest hope about the balanced brain is that it disrupts people's preconceptions of mental health as something social, cultural, intangible, into something measurable, physical, and therefore changeable. And a kind of corollary of that is I hope it grows your appreciation for the commonalities of many different mental health approaches. There isn't, a good one and a bad one, a psychological one and a physical one that's somehow pejorative that we should shame, and one that's fine that anyone can do, one that's harmful and one that is harmless. All mental health interventions come with benefits, but also with side effects. And I think we should kind of take everyone with that consideration. We shouldn't discount, for example, side effects of psychological interventions just because they don't come on a warning label like antidepressants. By the same token, we shouldn't consider, really cool new treatments like psychedelic drugs in a somehow new category from previous drug therapies for mental health conditions. They're another drug and they need to be tested like other drugs with good control conditions in good trials. So that would be my hopeful takeaway.
That is wonderful. Professor Camilla Nord, I would like to thank you for having joined on this episode and describing a bit from the balanced brain about neuroscience and behavior as people that we are.
Thank you so much.
Glad to have you on, and we are out.